Good morning, good afternoon, and good evening, I guess, depending on which part of the world all of you are in. And welcome to this session of the C3 Fellows and Young Practitioners Forum. It gives me great pleasure to have with me such a distinguished panel here today. From Atlanta, I have, my name is Gautam Kumar. From Emory University and the Atlanta VA Medical Center. I will have my co-panelists introduce themselves. Dr. Rajesh Sachdeva.
You're muted, Raj.
You're muted.
Perfect. Hi, good morning, everybody, and welcome to the conference. Thank you, Dr. Dave and Dr. Kumar, for having me as moderate the sessions. This is a fantastic conference. I am Rajesh Sachdeva. I'm an interventional cardiologist with Atlanta VA.
Dr. Arasi Maran.
Yes, thank you, Dr. Kumar, and thank you, Dr. Dave, for this wonderful opportunity. It's always such a great pleasure to interact with fellows. I'm Arasi Maran. I'm an interventional cardiologist at the Medical University of South Carolina. I'm also the director of the CTO program there. I'm very excited to be here today.
And Dr. Kwan Lee.
Thank you, Dr. Kumar and Dr. Dave, for this wonderful opportunity to be part of a global program such as yours. My name is Kwan Lee. I'm an interventional cardiologist, the medical service line director and director of intervention, as well as associate program director for the University of Arizona Banner University Medical Group program in Tucson, Arizona. Happy to be here.
Excellent. Well, without, we have several great presentations lined up for today. Again, this is part of the C3 Fellows and Young Practitioners Forum series, and I think this has been the third or fourth in this particular series. It's been going on for close to 9 months to a year now. Again, it's great to have all of you. Let me go ahead and introduce our first speaker, Dr. Chan Ho Thum. And Dr. Thum serves as a cardiology fellow and clinical specialist at the National Heart Institute in Malaysia. He earned his MBBS from International Medical University, Malaysia, postgraduate degree in internal medicine from his Royal College of Physicians. And subsequently, he trained in Malaysia, Putrajaya Hospital, as well as the National Heart Institute in Malaysia. He has training in cardiology, imaging, heart failure, and EP. And he's actively involved in several post-PCI registries to date. He is here today to tell us about Leave Nothing Behind, the role of drug-eluting balloon after an orbital atherectomy. And with his background in DCB, I'm sure this is going to be a great talk. Dr. Thum, please.
Okay. I shall just start with the screen sharing. Hello, good morning, everyone. Sorry, good morning. Let me just screen share first. Okay, screen share, and then go to the top. That's okay. Everybody can hear me fine and see the screen, right? Okay. Good morning, everyone. I'm Dr. Thum here from the National Heart Institute of Malaysia. First and foremost, I'd like to thank the organizers for letting me take part in this prestigious event. Without much further ado, I shall be talking about a case today, aptly titled Leaving Nothing Behind, the role of post-orbital atherectomy. So firstly, we do a bit of a brief clinical history of the patient. Mr. PBA, a 67-year-old gentleman, has no significant comorbids. He, however, is a chronic and heavy smoker. He presented to a district hospital with severe typical anginal pains, and his ECG showed ST elevation at the anterior lateral leads. Fortunately for him, he was successfully thrombolized with resolution of symptoms and ST elevation. His echo revealed hypokinesia at the LAD territory with an EF of 44%, and he was referred to us for further cardiac management and intervention. This is just an echo example of his echo on the pasternal short axis and the 4-chamber view. As we can see, there's hypokinesia at the LAD territory, especially the apical region. So at our center, he was actually fairly asymptomatic when we saw him in the clinic. He was well. New York Heart Association class was 1. We decided to perform a coronary angiogram for him for further assessment. So he basically has a 3-vessel disease. The left main stem is spared, but the culprit vessel, the left anterior descending, has 2 severe lesions, a severely calcified proximal and also a severely calcified mid-LAD disease with also severe D2 disease. The third, just moderate disease with a bit of OM1 disease, severe OM1 disease. The right coronary artery shows mild irregularities with only distal PD and PL disease. So this is the angiogram. On the caudal view, we can clearly see that there is what you call that moderate disease of the circ, severe OM1 disease, but the most important thing is the proximal to mid LAD disease at the back there. Spider view just only further accentuates there's at least a moderate circ disease, but you can see, although there's an overlapping there, we can see there's almost a discontinuity between the proximal and mid LAD. On the RCA, it's just mild irregularities with only severe distal disease. So we proceed with the culprit vessel, which is the LAD. So on the angiogram video here, even before the angiogram, you can see a faint silhouette of the LAD, indicating there's already calcification on board. With the contrast, we can see there's one stenosis here and another stenosis, significant stenosis here. We're looking at the RAO cranial view just to show the severity in another view of the proximal and the mid lesion. So, okay, these are the 2 lesions of the LAD. Before we proceeded with any intervention, we also noted that there's a bit of hypokinesia at the apical region. So before we see if it's feasible for any intervention, we just proceeded with a quick PET-CT scan for our patient. Fortunately for him, there's only a small distal LAD infarcted territory. The rest of the LAD areas are viable, with a bit of peri-infarct stress-induced ischemia at the mid-LAD. So since it is feasible, we proceeded with a stage PCI to the calcified LAD. We are expecting to be using debulking techniques for this procedure. So we use a right femoral approach with a larger catheter, EBU 357 French catheter for better support. In just 2 weeks after the initial angiogram, the repeat angiogram showed quite a rapid progression of the disease. Now, there is a subtotal stenosis of the proximal LAD with very slow flow down the LAD. Fortunately for us, we managed to cross the lesion with our basic workhorse wire, the run-through floppy, and then pre-dilated the proximal lesion with a 2010 semi-compliant balloon. Post pre-dilatation, we can see there's TIMI3 flow, and this enables us to introduce our IVUS into the system. So this is what we found on our IVUS. Not surprisingly, the IVUS revealed significant concentric calcification on the proximal and also the mid-LAD, with, of course, reduced in lumen size. So, of course, our next decision would be for debulking techniques. We chose the orbital atherectomy, or OAS, which we performed. We had a few runs of the OAS up and down the proximal to mid-LAD region, followed by further pre-dilatation with a scoring balloon, 2515, at the proximal and mid lesion. Post pre-dilatation, we repeated the IVUS. The mid lumen was effectively increased in size from 3.4 mm squared to 4.6 mm squared. However, the proximal lumen, there's only a modest gain of improvement from 3.04 to 3.28. Furthermore, later on, I'll show the IVUS again, the concentric calcification is still there. Okay, and then ideally, there should be more debulking at the proximal LAD region. However, as you can see so for yourself on our, okay, hold on, let me just move my picture away. Yeah, okay, so as you can see so on the video here, this is the stenosis area that has inadequate debulking yet. And of course, however, there is some dissection over at the mid-RCA, mid-LAD already. So whenever there's a dissection, unfortunately, we are unable to proceed with a OAS because that would only worsen the dissection. So hence comes the dilemma. What should we do next for this patient? Of course, one way, reflexively, when we see a dissection, we would want to stent the area because it will also help to control the dissection. Unfortunately, with such calcification present, we are worried that the stent may be inadequately expanded or malapposition, and that will lead to future problems or even subacute stent thrombosis. Hence, with this in mind, we have actually decided for an alternative approach which is the use of drug-coated balloons. So for these lesions, we use a two drug-coated balloon strategy. For the mid-LED, we use a smaller one, a 2530 paclitaxel drug-coated balloon, which we managed to deploy without much difficulty in the mid lesion. For the proximal lesion, we use a 27530, which went in smoothly and out also smoothly, deployed well. However, there was a recoil at the proximal lesion of less than 30% post-DCB. Of course, this is not surprising because the calcification there is still present. So now here comes the time of the important timing, whereby now we have to monitor the patient in our lab to see if there's any progression of the dissection or not. So we're looking into things like staining, slow flow, and also see if the dissection changes or increases in size. Fortunately, the dissection persisted, but it did not worsen. After half an hour of observation and repeat angiogram, there was still TIMI3 flow. Hence, the results were accepted. He was sent to the CCU for monitoring for 1 day, and then after 1 or 2 days later in the normal ward, we discharged him without any complications. So this is the final angio results for the patient. Obviously, it's not aesthetically as perfect as should we successfully debug the patient completely and stent him, but this is what we can accept for now. So as we can see, definitely the lumen size is much better than the first angiogram. However, you can still see the residual stenosis of the proximal LED. In the cranial view, the stenosis is apparent. The dissection is still there. However, there's still TIMI3 flow. And of course, the RAO cranial view, we can see there is still a residual stenosis, but the flow was fairly well. Hence, we accept the results for now. So we go into the IVUS results. Let me go there. So the IVUS results are showed proximal LED, not much improvement. Concentric calcification is still there, and the diameter, the area of the lumen is just minimal increase, minimal improvement. For the mid LED, much better improvement, but however, there's of course some dissections involved as well. So at this juncture, of course, this is not the best we can do. We could have done better with more debulking and stenting, but because of the dissection, we have to take a step back and use this alternative method. What we plan to do is, of course, to restudy in 6 weeks to 2 months later. Should there be significant stenosis or ischemia or even worsening of stenosis, by then we can do further debulking and stenting if needed, because by then dissection would have already healed by then. So with this, I conclude with a few take-home messages. Basically, when we see a calcified vessel, obviously we need proper preparation of the vessel to avoid incomplete stent expansion and apposition, which could lead to troubles in the future. And how to properly prepare the vessels within imaging modalities. IVUS or OCT is useful to assess the degree of calcification, the degree of stenosis, and they will help us plan the next step of PCI. Drug-coated balloon is a very useful tool, a very useful alternative in management of all our coronary interventions now. Not just for ISRs, not just for small vessels, now even in de novo, complex cases, and even OAS cases. And whenever there is a dissection, drug-coated balloon can still be used, but with caution. Type A and Type B dissections, usually not an issue. Type C, if the flow is good, new evidence has showed that Type C, we still can use drug-coated balloons. With that, I conclude and open to further questions from the floor.
Okay, that's excellent. Before we go further, I wanted to introduce my good friend and usual partner in crime, Dr. Goran Olive-Korna, who is here from Sweden as well. And since you're here, Goran, and I have such great experience with drug-coated balloons in the United States, in the coronaries, which is non-existent, unfortunately. I will have you start the ball rolling by saying what you think about this case so far, Goran.
Thank you, and it's a pleasure to be here. Nice to see everybody. I think it's a very, very interesting case. We've been using drug-coating balloons for a long time. I think one of the key things is that if you ever do an orbital atherectomy or rotablator or something like that, it produces horrible restenosis unless you put either a drug-eluting stent or a drug-coating balloon in. So I think that was definitely the right decision. But I think you're looking sort of for this is one step in the procedure of the patient, and he's going to be coming back. I think you're probably going to need to do some additional work, but at least to sort of solve the issue of flow to the distal LAD, and it'll be interesting to see what it comes back. There is a hot Dutch study where they actually treated STEMI patients with drug-coated balloons only compared to drug-eluting stents, and that showed that it works quite well. So interesting. I think I would have probably done it a little bit differently. I would have at least tried with larger balloons in the proximal part of the LAD and see if you couldn't get, expansion. If I got a dog bone in that, then I think I would have left it like you did. So, but very nice presentation. Great job.
Thank you.
So, Dr. Thum, we are going to have you come back and present to us, and you can feel free to email me when you have the final case, when the patient comes back as a follow-up to this presentation, because we would love to see that. Dr. Sachdeva, do you have anything to add?
So the other way, leaving a dissection, especially in the LAD, I think is a bit of a risk. You've seen that with the first presentation to the second angiogram that the LAD had occluded, and now you left the dissection. I would probably be hesitant leaving the dissection in the LAD. I don't know whether you have shockwave available. So to sort of mitigate this and leave with a good result, I would go ahead and stent, try to expand the stent. If it doesn't work, shockwave will be the way to go, and try to break the calcium and see whether you get a good expansion.
We just got the shockwave machine only. Still quite not much experience with the shockwave from Malaysia.
Dr. Thum, were there any dog boning when you inflated your 2.75 millimeter?
So the 2.75 balloon actually it expanded quite well, but then it recoiled back. There's not much dog boning. I apologize for not adding the videos inside.
Because it looked like your reference vessel sizes were about 2.75 to 3.0, and
yes.
dog boning there. One could clearly make the argument that you could just have gone ahead and stented it with a drug-eluting stent.
True.
I concur with the excellent comments earlier. Dr. Corona, has DCBs been shown to be superior in any way, or at least equivalent in the European trial so far in this type of setting?
The Dutch trial showed non-inferiority, but this was STEMI patients.
STEMI patients,
so this is post-STEMI, so it's not really applicable. But I think that they work reasonably well, but it's primarily done from one manufacturer. So it's a little bit of an issue also. It's one drug-coated balloon, something that can be extrapolated to all the drug-eluting balloons.
Yeah, because the incipient...
Sequence, please, Goran, that you're referring to. Yeah. Okay. Dr. Maran, in your experience with complex PCIs and CTOs, how would be your approach to this case? Unmute.
One of the interesting part of interventional cardiology is we hear so many different approaches to the same problem here. I think Dr. Thum's approach is one way, and as Dr. Sachdeva said, there are multiple ways, other ways we could have done with this. I would have tried a cutting balloon to the proximal vessel and see how that expanded. And my goal would be to produce fractures within the 360 calcium rather than debulking, so that allows for the stent to expand. And if the cutting balloon expanded well, I would have IVS to see whether I've produced fractures, and I would have probably stented it. But there are multiple ways to skin the cat. And as you said, let's get the final picture after you've stented bring the patient back. That would be extremely interesting.
Okay, very good. So we're going to hear from Dr. Thum again in a couple of months after he has done this case again. Thank you very much for presenting. And now we will move from Malaysia and move on to Italy, where we have Dr. Vincenzo Cesario, who is going to be telling us about percutaneous coronary intervention for left main disease in a patient with a history of Kawasaki disease. Dr. Cesario is a cardiology resident at Sapienza University in Rome and will be doing interventional cardiology in Rome as well. He has been involved extensively in research in bioresorbable polymer-coated synergy stents, as well as he's done some work in aspirin resistance as well. So his main areas of interest include cardiogenic shock, left ventricular assist devices, and complex coronary intervention. Vincenzo, please.
Hello, good morning, dear colleagues. Do you hear me?
Yes.
Okay, perfect. I'm very glad to participate in this session of the Interventional Academy. So I share my okay. So I show you a clinical case of percutaneous coronary intervention for left main disease in a young patient with coronary aneurysm and history of Kawasaki disease. So we have a 45 years old gentleman with a history of Kawasaki disease when he was 12 years old. A previous coronary artery bypass graft with left internal mammary acting LAD. And, he's on medical therapy with FASE inhibitor, cardioaspirin. So they came to our attention in our emergency department for chest pain with proper elevation on EKG, diffuse ST depression on the cordial lead. And we noted on echocardiogram that reduced ejection fraction without any clear area of initial. So we performed coronary angiography. We can see here the graph for LAD without any significant notice. With lateral circulation for right coronary artery. In fact, that artery show a chronic total occlusion in its first tract, and the left coronary show severe stenosis in the central body of the left main with a huge aneurysm of the left main. Total occlusion of LAD, a good intermediate artery, circumflex artery with a moderate disease and some inflammation, but without any significant notice. So, which is the best therapy for this case? We don't think that medical therapy was a good option for the prognosis of this young patient and for the kind of patient. Redo for the grafting could be a good idea, but the patient absolutely refused the idea, the option of graft surgery. So we go through percutaneous coronary intervention. In this study, better the lesion you can see here another view main stenosis. And we perform also intravascular ultrasound with a radiofrequency analysis with virtual histology to better understand the tissue composition of the plaque and to provide a more detailed description of the plaque. And as you can see in this image, the plaque is composed for most of fibrotic tissue that is represented here of dark green color, and fibrofatty tissue that is light green color, with some spot of necrosis that are this red spot and calcification that are white spots, for a total plaque burden of 81% high plaque burden, and with a minimal lumen area of 5.8. So, first of all, we performed a predilatation of the stenosis with a non-compliant balloon, 4.5 millimeters of diameter for 12 of length. This is the result of the first predilatation. And after that, we go with a stent implantation of 4.5 for 12 millimeters of drug eluting stent with azotarolimus eluting stent. And after that, we perform a post-dilatation with a non-compliant balloon of 5 millimeters, 12 millimeters of length. And this is the final result of the figure, with a good angiographic result in our opinion. We performed also a check with IVUS after the stent implantation, and you can see here in this image stent, the patent stent inside the left main, and here the image of the stent positioned at the point of the images with good meaning. So the patient was discharged 2 days after the intervention without any complication, good clinical status. Thank you for your attention.
Excellent. Thank you, Dr. Cesario. I guess I may have a question that may be irrelevant to the procedure, but more relevant to post-operative care. What is going to be your DAP strategy for this patient, or anticoagulation strategy, or what are you planning with respect to that with such large aneurysmal arteries?
So we left the patient on cardioaspirin, and for the second drug for antiaggregation, we gave him ticagrelor, and we left him without any anticoagulation. So a double antiplatelet therapy, because we treated him as an STEMI, because he's an STEMI. But what do you think? In your opinion, is a patient who can take some benefit from anticoagulation therapy for the aneurysm? What do you think of anticoagulation? Because in our opinion, there are no much evidence in literature about anticoagulation for this kind of lesion. What's your practice?
Before we proceed, can I ask one question? Within your IVUS images, was there much stent malapposition in the distal edge, in the section protruding into that aneurysmal trifurcation? You didn't show that on the IVUS earlier? Or did you manage to get it pretty much flush with the walls?
Sorry, may you repeat?
With your IVUS imaging, was there any stent malapposition? Did the stent protrude a little bit into that aneurysmal area, as in, were there stent struts that were free floating? Or were you able to stent almost precisely up to the line of the aneurysm?
No, we stented precisely at the level of the aneurysm.
That's perfect. Yeah, so, I think from my standpoint, because of that, I wouldn't change management. I would just adhere to the standard DAP protocol, whatever your preference is for, DAP protocols in your country with regards to this type of stenting.
And you wouldn't consider prolonged DAPT either, or would any of you consider prolonged DAPT in this kind of?
I might consider it if he tolerates DAPT well in the first few months. He does not. He's young. He doesn't seem to have any specific HBR risk factors. So my preference overall is I tend to push the DAPT longer. Sometimes I switch over to the twilight strategy. But I think for him, we would probably just use that for a year. That would be my preference, and then stop, and then aspirin. But I know it would not be unreasonable to argue for shorter DAPT durations.
Actually, I have a question for Dr. Goran. Would a drug-coated balloon have been useful in this scenario? Because with aneurysmal segments, you always, like Dr. Kwan said, apposition can be an issue, or has there been any use of drug-coated balloons for these situations?
Great question, that's one thing that I was thinking of. We don't know what the progress is going to be here, if this aneurysm continues to grow or not. So it's very little work done in this area, but it's something that I have occasionally used as a strategy. Usually, when they come in with these grossly aneurysmatic right coronary arteries, and you have thrombus formation and so on. And then becomes a really interesting question also what type of anticoagulation or antithrombotic type of strategy to use afterwards. But occasionally in the right coronary artery, this particular case, I think I probably would have gone with a stent just like Vincenzo did. Anybody other have any comments?
I thought it was nice to see that the Lima was open, almost 30 years later. I mean, he had that done when he was 12, and he's 47 now. It's quite reassuring.
And the other comment I want to make is Kawasaki disease, it's a childhood disease. We don't see much of patients who actually have aneurysms and then are followed up in the adulthood age who have persistent aneurysm. And you can see over this much period of time, even with those aneurysms, there was nothing as a thrombotic event in these aneurysms. And I think these aneurysms are there, but they are somewhere in the range of 1.5 times the diameter of the vessel. So adding a DOAC or warfarin, I think will increase the bleeding risk, even though the patient is young. I think the benefit, unless until there was a thrombotic event, I would not actually propose to a triple therapy or a DOAC and a clopidogrel or ticagrelor therapy. I will just be purely dabbed on this patient.
Yeah, I think Dr. Sachdeva brings up a great point in that the decision to treat for this patient has implications in the duration of exposure of the treatment. If you were to treat a 60-year-old, 70-year-old patient, obviously their bleeding risk is higher, but the ultimate lifetime duration of exposure to anticoagulation is much shorter. In a 47-year-old guy, you might be subjecting, if you decide now, you might be subject him to 35, 40 years of additional, anticoagulation treatment, which would be a lot. And so I agree with you.
Yeah, but like what you said, a prolonged DAP strategy, like twilight type strategy, may be a valid strategy in this case.
Yes, that's why I'm saying I'm advocating against using anticoagulation.
Well, thank you very much. Oh, sorry, go ahead. You're going to say something.
No, just the last thing. In general, in our hospital, if we have a case like this with a patient without risk factors for bleeding, with a complex percutaneous intervention like this, our practice is absolutely to prolong the dual antiplatelet therapy. So, in our opinion, it's the best option for him without any anticoagulation.
Excellent. Well, Dr. Cesario, looks like you're in a site that does a lot of work with adult congenital patients. Is that correct?
Yeah. In our hospital, we see a lot of grown-up congenital patients. That would work.
So we look forward to hearing from you in future again with more cases. Thank you very much for presenting. Let me move on from there to Greece. And in Greece, we have Dr. Dimitrios Petroglou, who is going to be telling us. He's a board-certified cardiologist since October 2016. He has been done a lot of work with mechanical compression versus manual compression of the radial artery. And he is currently in the Interventional Cardiology Fellowship at, he did an Interventional Cardiology Fellowship at the Cardiology Department in Ionia, Greece. Dr. Petroglou, are you there?
Yes, I'm here. Can you see me?
No, we cannot see you actually.
No. Let me try something more.
We do see a blank screen and we're not able to see you.
Your
You
camera
should,
needs to be turned on.
His camera may be on, but we are just not able to see you.
yes, I have my camera on.
Can you share screen though?
Let me try. Yes, it appears that I can see my screen.
Yes, we can see your screen.
Okay, perfect. So let's begin. Unfortunately, you can't see me, but I can see you. Thank you very much. And I would like to thank the organizing committee for accepting this case to be presented. Good morning, everyone. Actually, good afternoon it is here in Greece. I'm very thrilled to be among all of you, although I would prefer to be live with you. So hopefully by the end of this presentation, our audience will be more familiarized with the techniques used to evaluate intermediate coronary stenosis, and in particular left main stenosis, which can be performed either anatomically with the use of intravascular imaging or functionally with the use of pressure wires. They will also come to know or remember these techniques' cutoff values, and they will be able to acknowledge the OCT and the value of OCT in PCI evaluation. So our case today is about a 67-year-old male patient, an active smoker with a history of hypertension and dyslipidemia, who had undergone a primary PCI to the right coronary artery 2 months prior in terms of an inferior ST elevation myocardial infarction. In that initial intervention, an intermediate distal left main stenosis was demonstrated, and the patient was readmitted 2 months later in order to have this stenosis more accurately evaluated. This is the distal left main stenosis we're talking about. We will see it from various angiographic projections. We estimated this stenosis both by the use of QCA and, of course, simple eyeballing to be around 40 or 50%. So we needed more and more accurate information about whether to proceed or not to an angioplasty. We decided to go on for anatomical evaluation. As already said, the anatomical evaluation is performed with the use of intravascular imaging, either with intravascular ultrasound, the known IVUS technique, or with the use of low coherence light, the optical coherence tomography technique, the OCT. And they both have the same cutoff value of 6 square millimeters, meaning that if the stenosis, if the lumen area at the narrowest part of the vessel is above this threshold, then the studies say that the lesion is not severe, while if it is below 6 square millimeters, then the lesion is severe and needs to be treated. So OCT it was for us. We wired both branches, the LAD and the circumflexatory, and we performed the OCT towards the LAD. And that is the image we obtained. Indeed, the narrowest part of the left main was far distally, right before the ostium of the circumflexatory, and the minimum lumen area calculated was 6.01 square millimeters, meaning right at the cutoff point. So with just such a marginal value, we needed to proceed and do some functional evaluation as well in order to be sure whether to stent or not. Functional evaluation, meaning using pressure guide wires, can be done either with the traditional fractional flow reserve, the FFR technique, which needs maximum vasodilation of the coronary microcirculation with adenosine usually, or papaverine and rarely other agents, and has a cutoff value of 0.80. Or with one of the two novel techniques, the IFR and the RFR, which have little differences in technical aspects between them, but they are both resting ratios. They do not need adenosine or vasodilation, and they both share the same cutoff value of 0.89. So we decided to proceed with the IFR technique, and a pressure wire was promoted to the LAD distal to the left main stenosis. And guess what? Once again, we were just at the cutoff point, meaning an IFR value of 0.89. So it was official by then that we had to deal with the definition of a borderline stenosis. Finally, and at last, traditional FFR gave us the answer. After adenosine infusion, we calculated a clearly pathological value of 0.71. So the lesion was severe and we had to proceed to a PCI. Because of the almost perpendicular offset of the circumflex ostium from the left main stem, and due to the absence of significant atheromatosis in the ostium of the circumflex artery, we prefer to proceed with left main bifurcation PCI with provisional standing towards the LCX. So after preparing the lesion with pre-dilations, we carefully placed a single stent extending from the proximal part of the LAD until the true ostium of the left main into the aorta. And after performing post-dilatations all over the length of the stent, every single step of a bifurcation technique was meticulously followed. So we performed a proximal optimization technique, a POT. We rewired the circumflex artery and removed the gelled wire, then double kissing balloon, and finally a POT once again. And also the final angiographic result was quite satisfying. We routinely use in our cath lab OCT in order to evaluate our PCIs, especially when it comes to proximal LAD or left main PCIs. And luckily, we did so this time. So we performed an OCT, and there was a great surprise waiting for us right down the corner. This is the image we took right at the distal edge of the placed stent. Although we thought that the stent was distally placed in a normal part of the vessel, it actually landed on an atheromatous plaque, as you see here. And in fact, it caused that plaque to crack in our 5 to 6. So we see here the cracked plaque, this endothelial disruption, and although this was a rather short dissection, we calculated to be less than 5 millimeters in length. At that point of time, we were not pretty confident to leave it alone, so we decided to place a second overlapping stent right distally to the first one. And that was the final result. Angiographically, once again, quite nice, but OCT was reperformed. And we were lucky for this because, once again, a second great surprise at a different part of the vessel this time was apparent. This is the image we obtained from the proximal part of the LAD right after the circumflex ostium. You see here in our 6 an image which is compatible with incipient thrombus formation. And it was this image that made us take a more close and careful look at our angiographic views. And indeed, we could say there was some kind of haziness in this point of interest. So it should have been thrombus, probably due to large dwelling times because of the complexity of our case. But we were rather surprised since we had repeatedly checked our ACT and it was never calculated in a value before 250. Nevertheless, since the OCT showed that the structure position was optimal, no further post-dilatations were made, and the patient was treated with an intracoronary bolus of 2B3 inhibitor tirofiban. And after some hours, the final angiographic result was as follows from a cranial and the caudal projection. The patient received intravenous tirofiban for 4 more hours, and he was headed to the coronary unit in order to be more closely monitored. He remained completely free of symptoms and hemodynamically stable for 24 hours, and he returned to the ward. Finally, 48 hours post-PCI, he was dismissed from hospital with no further complications. In our opinion, there are 2 major messages that must be learned from our case. The first one is that in real life and real patients, usually more than one techniques may be needed in order to accurately evaluate intermediate coronary stenosis and in particular left main stenosis. And this techniques may be either anatomical or functional or a combination of both. And the second one is that all of us interventionalists must acknowledge the utmost importance of intravascular imaging, and in particular OCT, for PCI evaluation, and especially in terms of early recognition of periprocedural complications, which would otherwise may remain overlooked, underdiagnosed, and the most important, untreated. And we should always keep in mind this kind of proverb. I don't know if you have heard it before. We love it in our cath lab. My mentor, Dr. Nikas, says that all the time. FFR shows you which lesion to treat. IVU shows you how to treat the lesion, while OCT shows you how you have treated the lesion. And at least principles number 1 and 3 of this proverb were totally confirmed in our case. Thank you very much.
That's an excellent case. Yes, I've heard a lot about Dr. Nikas, and I think in the coronary imaging and physiology field, he has done some pioneering work. Absolutely. This is just a great case that illustrates a lot of these problems and issues that we run into on a daily basis with left main stenosis. Now, I might have missed this, but was there a reason why you would not have considered bypass surgery in this case?
Because the patient presented with an ST elevation myocardial infarction. So we had already performed the primary PCI, and we were not sure about the severity of the lesion. That's why.
Excellent. Excellent.
So,
Dr. Sachdeva, go ahead, please.
Yeah. One question. So at the end of the procedure, it looks like you still have some haziness in the distal left main area where you said there was a thrombus. And then did you consider performing an intravascular ultrasound instead of OCT? Because OCT is not going to show what is beyond that thrombus which has formed, because it's a red thrombus. So you're not going to see these struts down there, whether you have a malapposition or you have a calcific nodule which is there, which has led to this, or there is a plaque protrusion. It will be difficult to see, but it's, you know, I would suggest that you do a intravascular ultrasound and see what's going on in terms of the stent is concerned.
Yes, you may be right. What reassured us was that we immediately started to infuse 2B3 inhibitor, and there was no thrombus expansion. So after several projections, we thought that the angiographic view was quite stable, and that's why we headed the patient to the coronary unit. But what you say does have a point, yeah.
I had a question. You mentioned that the OCT cutoff for intermediate left main decision-making is 6.0 millimeters squared. I know that's been shown quite well with IVUS. I'm not that familiar with the data for OCT, because in the early phantom studies of OCT versus IVUS, the measurements don't actually match up either. OCT tends to, for some reason, generate an undersized number by about 10% versus IVUS. Do you have any literature that supports that cutoff threshold of 6 for OCT?
No, the truth is that we simply extrapolated, and we chose OCT since we had to deal with distal left main stenosis, right? If we had to do with an ostial left main stenosis, of course, IVUS would be the first choice, since we would have a backflow of the contrast media into the aorta, and we would not have such a good imaging. But since we have a far distal left main, it actually worked, and no, it's simple extrapolation. I don't think we have more data about OCT.
I think I agree with both Dr. Lee as well as, you know, this is an important point to bring up. I think there is not as much wealth of data on OCT for these left mains as there is for IVUS, where there is a lot more data on these left mains. And there's also correlational data between IVUS for left mains. It's interesting that in the Japanese population, there were studies that go much lower for the cutoff for the left main, even as low as 4.8, for example. You know, if you have a big six person, I've personally had left mains that are 7 and are still physiologically significant. So again, I think you know, it's important to realize that, you know, we tend to use physiological measure to decide when we're going to stent. I think that's an important piece that we need to take into account. The real problem comes about is when you have a physiological left main lesion and you also have distal disease, and then you start asking yourself, is it the left main or is it the distal disease? And that's where life gets really interesting. Goran, you're smiling. What do you think?
I agree with you. And I also want to point out, I think it was an excellent presentation of the case where you're in the intermediate range. You've done your OCT, you've done your IFR, you're still borderline. And it also shows that there is a sort of a gray zone in between 0.89 to 0.92 for the RFRs and IFRs, that it's a great idea to add, a definitive sort of a measurement with FFR. So I think that was a great job. But I have one question. You did a kissing balloon. I don't know did we see any images? Was there a need to do a kissing balloon? I mean, if you have a good result and the circumflex offtake looks okay, I don't know, it's sort of a mixed bag what people want to do. I know the colleagues, Kwan or Arasi, Raj, want to say what would they have done if the circumflex looks good? Do you do routinely kissing balloon?
So go ahead, Kwan.
Good.
So, if the circumflex looks fine, there is no flow impairment, there is no stenosis I see in that area, I would not actually go and do the kissing there. On the other hand, if there is a stenosis or flow impairment, I will actually use FFR to determine that, and then at that point. But I will also use a smaller balloon, not smaller in length, not that long length balloon to actually do the ballooning of the circumflex. And partly my question about the first part of stent thrombosis was, that there is, you are actually moving these struts when you're doing the balloon. So it's important to actually look at those struts. If they are deformed there, that, your part may not have really flattened those struts completely. So IVUS may have helped in that case.
So I actually, being a person who comes across CTOs, many a times there's a left main to LAD stent and the circ, there's no final kissing balloon through the stent struts, and the circ becomes a CTO later on. And I struggle and curse the previous operator who did not do the final kiss. So just for the re-entry purposes, I actually prefer a final kiss and then do a part, just because the re-entry becomes so much difficult later on. So I think that's a personal preference. I'm not sure I can support my personal preference with a lot of data here, but whenever, and especially I feel like left main circumflex area is such a tough bifurcation. The chances of developing a future edge ISR or something is so high. So I personally prefer a final kiss with a part of the left main.
Yeah, my personal bias, as Dimitrios pointed out as well, is the same. Pot kiss pot. We always pot kiss pots our left mains. It's always fascinating that we talk about malapposition so much, but then in that specific setting, if you don't finish with a kiss, you are leaving significantly malapose stent sitting across. So my bias is to lean towards trying to come up with as OCT perfect an image at the end of the case as possible. But as you pointed out, Arasi, that whole debate is still continuing. And I think both approaches are viable. I love the fact, the last slide, I love the fact that Confucius was a great interventional cardiologist.
That might be plagiarized a bit, just so you know right now, Dr. Petroglou.
My strategy in a case like this, I would probably go with Kwan as well and RC as well. I would probably go with the pot kiss pot strategy. Again, for the same reasons, it gets to be a real pain if you want to do something in the circ later and the struts are not opened up. And but I do agree with Rajesh that I would go with a smaller balloon and not have a lot of it protruding into the circ. And if I really just need to do a part and there's not a whole lot going on in that circumflex, I may even go with a smaller diameter balloon as well, which may not necessarily even contact the vessel walls distal to the stent, just to get us some space and have a little open hole in that stent strut. But
So
again, there is
that's
zero
interesting.
data.
I have actually used one-to-one sizing based on IVUS imaging or something for the final case. But I mean, you are trying to just get the struts open. That's an interesting perspective.
Yeah. I mean, if you're not going to contact the walls, then you're not really, if it's disease-free, you don't want to have any endothelial injury. You just want to open up the struts and, leave space around it so that you can have something to go through in future when I'm going to send the patient to you for the CTO.
Thank you so much, Gautam. I won't curse at you. Don't worry.
All right. That's excellent. Thank you so much. That was a great case again. So now we are going to move on actually, we're going to come back to the United States for one case with Dr. Laith Durbus. And Dr. Durbus is going to tell us to stay on the left main theme about decay crush technique in distal left main bifurcation. And Dr. Durbus is actually doing his cardiology fellowship at Rush University Medical Center and has a lot of interest in interventional cardiology. So we would like to hear his perspective on this case. Dr. Durbus.
Thank you. It's a great pleasure to be here. Can you hear me?
Yes, absolutely.
Okay. Okay, let me try to share my slides first. Can you see my slides? Are you able to see my slides?
Yes.
Yes, please see.
Okay. Thank you, everyone, for inviting me and giving me the opportunity to present this case. So again, my name is Laith Durbus. I'm a cardiology fellow at Rush University, and our case today is post-TAVR left main PCI. So let's go ahead and get started. So our patient is an 87-year-old male, former smoker with history of coronary artery disease, history of prior PCI to the left circumflex in 2015. Patient has history of aortic stenosis that is post Edwards sapien valve implanted in 2017, end-stage renal disease on hemodialysis, type 2 diabetes, COPD, and partial pneumonectomy due to blastomycosis. Patient initially presented to an outside facility with the complaint of exertional chest pain that started about 2 to 3 days prior to presentation. Patient was admitted for NSTEMI. Troponin peaked at 15 nanogram per ml. EKG showed the T-wave inversions in the anterolateral precordial leads. So these are the diagnostic images for the patient that were obtained at the outside facility. And as you see here, there is a severe left main, distal left main disease involving the ostial LAD and left circ. There's also a significant stenosis in the mid-LAD that was deemed to be significant. So echo was obtained showing preserved left ventricular ejection fraction. Patient was offered a surgical revascularization for his complex disease. However, the patient declined the surgical option, and therefore, patient was transferred to our facility for a high-risk PCI. So the questions that were raised for this case were whether we're gonna use a hemodynamic support for this intervention, and if so, which device would be appropriate in the setting of a prosthetic valve. The other question was whether we need to use atherectomy, and the last question was what kind of technique would we be using for this bifurcation disease lesion in the left main. So the decision was made actually to use an Impella 2.5 device. The reason why we use this type of device is because we wanted to have an easy crossing through the valve using 2.5 Impella with a 12 French caliber is probably easier than using a bigger size caliber device. And the axis that was used was a left common femoral artery for insertion of the Impella. And then the right common femoral artery was used for our intervention using an 8 French destination sheath and an 8 French EBU 3.5 guide catheter. Given the heavy calcification of the distal left main and the ostial LAD and the left circ, we opted to proceed with rotational atherectomy of the distal left main as well as the LAD and the left circ. Therefore, a rotafloppy wire was used and rotational atherectomy with 1.5 millimeter burr was performed for both ostial LAD and ostial left circ, modifying the plaque burden for facilitating the delivery of the stents. Following that, we performed IVUS into the LAD I'm sorry, I apologize, I'm going to go back to the previous slide. So IVUS was performed to the LAD, and as you see, there were multiple lesions in the mid LAD as well as the proximal LAD and the distal left main. The distal left main size was measuring 3.8 millimeter by 3.7 millimeter. So first, we turned our attention to the mid-LAD lesion, and balloon angioplasty was performed to the mid-LAD with a NC balloon measuring 2.5 by 15 millimeter, followed by balloon angioplasty also to the proximal LAD to prepare the lesion in the ostial LAD as well. Then we used another balloon, 3.0 by 15 millimeter NC balloon for the same lesions to better prepare these lesions prior to stenting. Then we used Resolute Onyx 3.0 by 30 millimeter stent to the mid-LAD, showing good results. After that, we decided to proceed with the DK crush technique for the distal left main bifurcation. And for that, we first proceeded with side branch, the left circumflex side branch. First, we ballooned the proximal left circ with a NC 3.0 by 15 millimeter balloon, followed by a Resolute Onyx 3.5 by 22 millimeter drug-eluting stent. Next step in DK crush was to crush the side branch stent, and to do that, first we removed the wire, the cyan blue wire from the left circumflex, and then we used an NC 3.5 by 15 millimeter balloon and inflated it in the left main and the LAD to crush the stent in the left circumflex. Following that, we rewired the cyan blue wire into the circumflex by passing through the crushed stent struts. And following that, we performed the first kissing balloon using 2 NC 3.5 by 15 millimeter balloon. Following that, the side branch wire was removed again, and we turned our attention to the main branch, the LAD, to stent the main LAD lesion in the ostium using 3.5 by 30 millimeter drug-eluting stent. And as we mentioned earlier, the ostium was pre-dilated with stents in the first initial steps. When we were dilating the mid-LAD lesion, we dilated also the proximal LAD side. Therefore, it was ready for stenting at this point. Following that, we went ahead and performed PUT using 4.0 by 8 millimeter NC balloon. And after that, we rewired with the cyan blue wire into the circ again, passing through the newly placed LAD stent as well as the crushed stent struts of the circ, and performed another second kissing balloon using 2 NC 3.5 by 15 millimeter balloon. Then we performed a second PUT using 4.5 by 8 millimeter balloon. And as you see here, we performed a post dilation with the 3.5 by 15 millimeter balloon in the mid LAD as well as the proximal mid LAD to do post dilation of the both stents that were placed in the LAD. And this is the final PUT using an NC 4.5 by 8 millimeter balloon. Next slide shows final angiographic results. Apologize for the delay, but these are the final diagnostic image, the shots for the LAD and the mid LAD, as well as the proximal LAD stances and the bifurcation lesion. Following that, we performed IVUS, showing well expanded, well opposed stents in the mid LAD and the proximal LAD and distal left main. Then the Impella 2.5 was weaned and removed at the conclusion of the procedure, and a groin shot was obtained to ensure adequate hemostasis. So our take-home points from this case were unprotected distal left main bifurcation stenting can be safely performed using percutaneous mechanical circulatory support such as Impella device. Impella 2.5 can be considered for crossing previously present TAVR valve. Consider upfront two-stent technique for distal left main bifurcation stenting, particularly in the heavily calcified stenosis involving both proximal LAD and the left circ. And DK crush technique has been shown to be a preferred treatment strategy for distal left main bifurcation stenting. And thank you. I'm ready to answer any questions. Thank you.
Great presentation of a nice complex left main bifurcation. You know, there's just, and this is probably more of a commentary, which is probably based on personal style as well. I think in a case like this, I was watching for a larger burr to be used, given the fact that you picked the 8 French guide. And the largest burr you had was a 5 French, which, sorry, my bad, my 1.5 meter burr. And, you know, that may be a little undersized for ablation of this left main to produce adequate ablation, or it might be okay. You know, I think it turned out that it was okay. You know, if you have an 8 French guide, you could go with a bigger burr without really compromising on a whole lot. I generally tend to favor at least a 175 burr for the left main if I'm going to do a ablation of the left main. And that would probably be fit through a 7 French guide. So I'm not sure why an 8 French guide was chosen here as the choice, because again, your bifurcation strategy was DK crush, which can effectively be done with a 6 French guide as well. So this whole procedure could have been done through a 6 French guide. But again, you know, that's just a personal style issue. I'll ask the rest of my other complex PCI operators on the panel what they thought about that.
So I think, Gautam, we talk a lot about this. If the lumen of the left main is 4 millimeters square and you're using a 1.5 burr, the chances that the burr will touch that plaque is just hit and miss. Now, if there is some eccentricity of the plaque, you may actually do some of the cutting there or fracture the plaque. I think it's important to use a bigger burr, especially when you have an 8 French guide. You could have gone and ablated the left main with either a 2 burr and just shaved off. I'm not saying that you go further down into the LAD. So I think I agree with Gautam all that, that we should be ablating if we are actually planning and trying to expand these stents. We should be going with a little bigger heavy-duty burr. Yes, DK crush can be done through 6 French, and that you could have used only 1 axis and not used 2 axes. So you could have gone through the Impella sheath and put in your 6 French guide through there and done the whole case with single axis.
Although, Raj, they use a Impella 2.5, I don't think that can fit a single axis.
Yes, you're right.
I would have done exactly what you did, but I would just use an Impella CP so that I could just use single axis.
Yes,
so,
yes,
Dr.
thank you.
It's an excellent case. You did a fantastic job of going through the steps of DK crush, and it was very well done. And I have to agree with the rest of the panelists on the choice of burr. I might have chosen orbital atherectomy just because I can increase the speed and go with a slower speed in the left main, and therefore I get a bigger arc of cutting and maybe just a little bit faster in the left, in the LAD and the distal LAD to think. But these are all stylistic choices. So, I mean, it was very well done. And the final, the proof is in the pudding, and your results were fantastic. But these are all just thoughts for you to think about. The CP with a single access, you can save this person a whole nother femoral arteriotomy. That's something you have to think about in an older patient. And then also doing orbital atherectomy, you could have just gone with a 6-7 French, 7 French guide or a 6 French guide, things like that. Sometimes I've noticed in the post-TAVR patients, you need a guide extension to place the guide. I didn't recall, you didn't have to use that, did you? Okay.
No.
So sometimes, we use a guide extension, and I was thinking maybe that's why you chose a 8 French to park a guide extension catheter in the left main, and then you can safely, pass the burr without disturbing the stent struts the TAVR struts too much. But overall, very well done.
Thank you. I think we were thinking of first starting with 1.5 millimeter burr and then escalating to 1.75 if we found no good results, and also the fact that the balloon yielded good results is the reason why we did not escalate to the 1.75. But yeah, the 8 French at the beginning was to be able to do any changes throughout the procedure. And also using 2 axes was because 2.5 Impella device was used, and you cannot use a sheath for two devices or the intervention. And we used the smaller the 2.5 Impella is because we wanted to make sure that it's an easy crossing through the valve and avoid using the CP, which is a bigger device.
So just a question to the panelists. Sometimes with the Impella, the single axis Impella, it becomes tight and it becomes crowded. Any tips or tricks to avoid that, or what has been your experience with it?
So I have a number of strategies that I employ for this, and I will delineate them in point form. Number one, I tend to use the sheathless guide through the Impella. And I don't go through the same valve. I do a separate stick at 2 o'clock or 10 o'clock, and then, go on up with the wire and put the sheathless guide straight in. And that gives you a nice 6.5 or 7.5 French diameter with internal diameter that's a lot smaller. So that's, external diameter that's a lot smaller. The other strategies that have been employed is potentially you can put a long 6 or 7 French sheath inside and then put the guide inside of it. That minimizes a little bit of your resistance that you have going through the system as well. But then you have to take into account the size of that extra long sheath that you're putting in there as well. So these are a couple of strategies that we use. There are a couple of cases I have tried to just go with the 7 French guide with no sheath, a regular 7 French guide with no sheath through the Impella valve. That has also worked reasonably well. So, these are a couple of strategies that have been used. But yes, broadly speaking, you're right. There tends to be a lot of resistance in the system. And Laith, to add on one more teaching point for this, I think for a left main, your emergency bailout, well, there's actually 2 emergency bailouts. One emergency bailout you have is to just stent from left main into LAD and take whatever you can if things are all falling apart and everything is going to the dogs, so to speak. Your other emergency bailout is SKS, simultaneous kissing stent. The minimum size guide that will go through is a 7 French guide. It will not go through a 6 French guide. So that's another thing to just keep in the back of your pocket. If everything is going south and you have 2 wires down and you just want to stent and bail out, that's going to be a strategy. Put 2 stents, one into LAD, one into left main, deploy it in the left main and run. But yeah, I think that was a great case. I'll leave it to Kwan and Dr. Sachdeva to give their input on the long sheath and guides as well. I think Dr. Nikas wanted to add on that, yes, we can use the long sheath, but that tends to work only with the 6 French. With the 7 French, it tends to be a little too large, which has been my experience as well. Yep.
Yeah, I thought all your points were great. I've not knowing better, once I used a 6-7 slender, which is actually you're not supposed to do that, and then got a 7 French guide through it, and the whole thing went just fine. Surprisingly, I got away with it, but I think all your points were fantastic. And congratulations, Leif, that was a textbook case. Perfect.
Thank you.
So one of the things you can do also is, of course, not to forget about 7 French from radial.
Yes.
And I like when I do left mains to use 7 French because yes, you can do the 6 French, but you have much better options and less problems when you do your double kiss crush technique in this. And one thing that I've started doing more frequently is that when I do the crushing of the stent, I do it just like you did with a, I think you had a 3.5 balloon and from the LAD to the left main. Yeah. After that, the 3.5 is still sort of undersized. So I go back with, an extra pot balloon in the, prior to recrossing, because that will really ensure that the stent is really flattened out. So a short balloon and just the left main just to do a final crush, because sometimes you get into trouble when you get the second wire or you recross with your wire. And I've also gone away from the sign blue to the sign black for recross, because it's hydrophilic. It's still sort of blunt in the tip, like the sign blue, but it's less friction. And I find that easier to access with sign black.
Thank you.
One more point I want to make is whenever you're using a single sheath, embellished sheath, and you're trying to actually put guides and all that stuff, that space is quite tight. So you got to, and these are peel away sheets. So be careful about if you have a lot of resistance and you're pushing these things through there, you don't want to actually sort of peel this sheath, and then you will land up with another issue of bleeding through the sheath. So that can happen. So be aware of that part.
I just have on the chat, I think Dr. Kunkel adds an important point. She has routinely used the 6/7 slender with the 7 French guide for single access and has good experience with that. Yeah, that's great. All right, so we will move on to the next speaker, and we'll jump back across the Atlantic to Dr. Krishnaraj Rathod, who is the Interventional Cardiology Registrar at Bart's Heart Center, and he's also at Queen Mary University in London. He has done primary research in translational interventional clinical trials, including phase 1 and 2 trials, and his interests are in cost effectiveness of therapies and reperfusion injury and long-term outcomes following PCI. Dr. Rathod, are you there? Ah, there you are. Perfect. We cannot hear you. You may be muted.
Oh, can you hear me now?
Yes, we can hear you now.
Oh, thank you. So thank you very much for this great opportunity to be able to present in front of a great panel and a great audience. And all the cases so far have been amazing. So thank you for that introduction. So I'll be presenting my case of a tale of 3 angiograms, which I'll talk you through. I have no financial relationships to declare. So this is a 58-year-old gentleman, Afro-Caribbean in origin, who's type 2 diabetic, hypertensive, hypercholesterolemia, and an ex-smoker, an ex-heavy smoker, has extensive coronary artery disease, initially managed medically. He presented to our clinic with CCS class 2 angina, and then had a myocardial perfusion scan with stress demonstrating reversible ischemia in the anterolateral territory. So he had this angiogram performed, which demonstrated significant disease in this proximal to mid LAD. So he had a drug-eluting stent deployed. This is 2016, a 3.5 by 23 millimeter Zion stent with good result. At this time, although he had an angiogram of the left coronary artery quite successfully, the operators at that time were not able to find the right coronary artery, and they felt it was probably a small caliber non-dominant vessel and didn't try very hard. He subsequently presented again with more chest pain in March and a small end STEMI with a troponin rise. And at that time, there was progression of some disease in the first and second obtuse marginal branches. This time he had pressure eye to the LAD, which was negative at 0.85. And he therefore had treatment of these 2 branches, as it was thought these might be the culprit. So he had a 2.5 by 38 millimeter and a 2.75 by 33 millimeter stents deployed in these 2 branches with, again, good result. At this time, the operators tried a little bit harder to find the right coronary artery. So they used a JR4 diagnostic and it did a non-selective view and couldn't really see any ghosting. but they performed an aortogram using a pigtail catheter. And again, they didn't really see much, and again, felt maybe this is a non-dominant right coronary artery, and left things alone. He was then seen in clinic a few weeks later. And he said, look, my angina is not improving at all. I'm still getting the same amount of chest pain before this last procedure, and there must be something wrong. So at that time, we thought, if we've got CT coronary angiogram that's just started, why don't we have a look with the CT coronary angiogram to delineate the right coronary artery? And actually on the CT coronary angiogram, you can see there is a right coronary artery, and it's quite sufficient, big in size. It doesn't look non-dominant. And if you look at a different cut, and there looks like a big right coronary artery with some calcification, which at least at 2 points, which I'll come back to a bit later on. We have the ability now to perform 3D reconstruction, and therefore we carried this out to be able to see what is happening with the right coronary artery, and to make sure it's not a malignant cause, because this would obviously change the management. Because if it was a malignant cause, then he would be possibly offered further stress tests or surgery. And you can see the right coronary artery actually isn't malignant, it's just a aberrant RCA coming off the left coronary cusp. Now, in our institute at the moment, we're currently carrying out a study where we can fuse CT with angiography. And what we did is to make it easier for us to find the right coronary artery during the case, we fused the findings of CT scan on the angiogram. And at this time, it was almost very straightforward to be able to find the right coronary artery. So during this angiogram, I used an AL2 guide catheter and went straight for the right coronary artery. Initially, obviously checked the left system and the stents were patent. There wasn't any further disease. And you can see in this LAO view, there's a long, big right coronary artery with disease in the proximal vessel and distal vessel. It's quite diffuse throughout. This is a REO view, again, demonstrating the long diffuse nature of the disease. And same in the PA cranial view. Now, this was a run through hypercut wire, which is my workhorse wire, which I often swap and change with the cyan blue. And you can see there's a guide catheter extension as well, because the AL2 wasn't completely sitting that well in the ostium. And this would provide us a little bit more support, because I suspect we're going to have to do a few things here, including intravascular imaging. So first of all, what we did IVUS, and what we found, actually there was napkin ring calcification in the distal vessel, and also significant calcification, not completely napkin ring, but at least, more than 270 in terms of the burden of calcium. So at this point, we thought, let's see if we can try some non-compliant balloons. And we started with a 2.5 by 20 non-compliant balloon. And in the majority of these places, there is yielding of the atheroma and calcification. But actually in this point, there wasn't sufficient yielding. You can see it's dog boning. And so we therefore decided to use a cutting balloon, a Wolverine 2.5 by 15. And again, the result wasn't great. You can see there's still constriction in the middle. So at this point, we thought, there's a few options. We can manage this gentleman medically, use a drug-eluting balloon, maybe just stop there, but he's got sufficient angina. The second option is to use a rotational atherectomy. So we don't have the orbital atherectomy here, but we do have rotational atherectomy to ablate. But the setup for that was going to be a little bit complicated. We thought, we may not get the burr around, and it's quite difficult that we've got to this position already. So we've recently, or in the last year or so, we've got this technology, which we've mentioned before. So IVL or shockwave, so we can deliver shockwave balloons relatively easily to provide therapy to fracture calcium. So we decided to use a 2.5 by 12 millimeter balloon at 4 atmospheres, and then at 6 atmospheres, you can already see that there's yielding of this lesion. We did the same thing at the proximal, because we know that there's calcium there and we had the balloon there, so why not just use that same position? And we did that. And in fact, after this, a 3 by 20 millimeter non-compliant balloon had sufficient yielding of this lesion, and the dog boning had disappeared. Confirmed on IVUS as well that there was significant fractures of the calcium. Same in the proximal vessel, there was significant fractures and there was good yielding with the balloon. This is the angiogram just after the IVL, and you can see that there's good angiographic result already with improvement in size. We then decided to use stents. So we chose Synergy stents mainly because we found them more deliverable than our other brands that we have. This patient didn't have any issues with dual antiplatelet therapy, but we know that they're more deliverable. So we use a 3 by 48 millimeter, which is overlapped with a 3.5 by 2.75 by 38, then a 3 by 48, and then at the top a 3.5 by 20 millimeter stent. And these are the final angiographic pictures. We reconfirmed on IVUS that all the stents were well opposed, and we did post dilate with 3.2535 and 4 millimeter NC balloons. So summary and takeaway points. Essentially, this patient had a aberrant right coronary artery, which probably wasn't managed very well initially because it was never really found. But once found, we know there was significant disease. CT coronary angiogram with fusion gave us a great view of the right coronary artery, the origin of the ostium, and being able to fuse it, reduce the amount of contrast needed at the time of the procedure, hence risk of complications. We started off using a supportive wire. So I forgot to mention, we changed the run-through wire to a Sine extra support wire to enable extra support, and a guide catheter extension was used for the same reason. And in addition, I've found that using guide catheter extension does reduce the amount of contrast you often need because of the better opacification. And intracoronary imaging using IVUS provided us great view of the amount of calcium, which then enabled us to use calcium modification techniques such as IVL of shockwave. And he's remained symptom-free since, which is the best news. Thank you very much. I'm happy to take any questions.
Great presentation, Krishna Raj. I wanted you to, I'm going to play the devil's advocate here. So I'm going to have you go back to your final image of the circumflex or ramus or OM, whatever you want to call that.
Sure.
The very final image post-PCI of the circumflex.
So while he's going back, I want to ask the panelists, what would they have done?
So what do you think proximal to that stent?
Yes, there is disease just proximal to that stent, and I don't think there was any imaging performed at that time, and I suspect there's sufficient or significant imaging. There wasn't, however, any reversible ischemia on a non-invasive test, which I forgot to mention. But I mean, yes, angiographically, that I would have interrogated that a bit further.
Yeah. And but yeah, otherwise it's a great case. I had one more question. Was any physiological assessment done of the RCA? I mean, it looked tight, but sometimes in these cases it might help to hop a FFR wire across and quickly get some kind of a resting index RFR or IFR or whatever you prefer, or even just a
absolutely. Yeah, no, absolutely. That's a very good point. Well, we didn't at that time. We just thought that angiographically it looked tight, and IVUS actually looked quite tight. So we decided to treat it, presuming that his symptoms are coming from there. But I mean, yes, we didn't have any physiology data at the time.
Yeah, Dr. Sachdeva, you had a question.
So I wanted to ask the panelists about what would they have done. Let's say there was a limitation in US that shockwave balloon, which now is available, but it was not available in the past. Would they have just chosen the rotablation? And if they would have chosen the
past, it was just 2 weeks ago that it was not available.
Yes. So would they have chosen rotablation over orbital? And if they have gone with a
Arasi, what do you think?
I mean, I think number one is, this is a case where the patient is always right? The patient kept coming back, and incidentally, other diseases were found, whereas the main problem was the RCA. I might have sent him for a CT angiogram after the first PCI and not waited for 2 other angiograms. That's number one. Number two, I would have chosen rota for this because it's anomalous and it's, you have a guide excision catheter, etc. I would have gone with the 1-2 fiber, clear a path, get a stent in, and get out. This would it would have been, yes, difficult and miserable and painful, but if you can, this is a great case of where shockwave lithotripsy saves the day. But since we just got it 2 weeks ago, and if I had to treat it, I would have struggled and fought with the rotablator for as long as it takes to get it done.
So would you choose a 1-2 fiber or 1 fiber?
1 fiber. I hate 1-2 fibers because, I just feel it might deliver a stent, but you may not get adequate thing. But I would be worried whether I would be able to deliver a one fiber, or I would have. I think more than likely I would have taken the guide extension as much as I can to the lesion and then gone with the one fiber. I think the guide extension catheter is going to be the savior in this case.
So, Dr. Maran, I share your affection or lack thereof for 1-2 fibers in general as well. Yeah.
So,
one of the questions
what about CSI?
Just 1 second, we'll go with Rhoda for a second. One of the questions that comes up to the panel is what size burr will go through a 6 French guideliner? Will you be able to get a 1-5 burr through a 6 French guideliner? I'm pretty sure you can get a 1-2 fiber. Will you be able to get a 1-5 burr through a 6 French guideliner? Anyone has any experience with this?
Yes, I have tried both, and you can't get a 1-2-5 through a 6 French guideliner. You need at least a 7 French guideliner. So that would be the reason to do a 1-2-5 burr in this case, or at least get a 7 French guideliner. Whereas with a 6 French guide extension catheter, you can get the CSI down. I have done that, and I think it was published in Cath Lab Digest long time ago. So yes, I've tried both, and you can do a CSI through a 6 French guide extension, but not a 1-2-5 burr.
So what about orbital atherectomy? Who would lean towards orbital atherectomy in this instance? I think it would be reasonable to consider orbital atherectomy for the reasons that we talked about, we can get it through the guideliner, get it there. And I've also done that several times before. Kwan, what do you think?
Yeah, I agree with Arasi. I would have stuck with rotoblader. The calcification is very focal. It's in 2 small spots. Despite the technical advantages of the 6 French with the orbital, that's a lot of atherectomy device to deliver a long way down. While with the rotoblader, we can be more focal about it, right? Because all you needed to do was crack that calcium in that spot. You saw clearly from your predilatations that even the proximal stuff you didn't really need to debulk. You just need to just crack the calcium and then you'll be good to go.
I have actually done a 1-2-5 burr through a 6 French guideliner, and it's actually gone down a lemma into a CTO of a distal LAD, and I've done rotational atherectomy of distal LAD through the lemma with a 6 French guideliner, and this was successful. Yep. So yeah, it is possible to get a 1-2-5 burr down a 6 French guideliner. In my experience, I've managed to do it in an extremely difficult clinical scenario.
You're just showing off now, Gautam. You're just completely showing off now.
Yes. You're welcome.
But one thing to keep in mind, though, here is that shockwave, although it's great, and I think it was a fantastic case, but it's not always, it's a little bit bulkier. So you're by no means certain that you're going to get that in place. So, being this far distally out, I think that I would have gone first with a rotoblader also. But shockwave is quite expensive here in Europe, so and rotoblader is something that we're used to, and now we've just gotten orbital atherectomy. They've been CE marked for years, but they aren't selling them until just recently.
Now, Goran, let me ask you a question. What would be a kind of a scenario here, whether this would be a good case for what you would consider to be like a rotoshock? You put a 1-2-5 burr through a guideliner, do the rotational atherectomy, and then take a nice 2-5 balloon or even approximately a 3-0 shockwave balloon. Let's just put the cost factor out of the picture for now. Yeah. What do you think about that in this scenario, rotoshock?
I think that rotoshock has its major place in a large artery where you need to be able to do rota to even get the shockwave balloon, but it can save you a lot of time of going up, up to the 2.0 balloon, for example, and really crack up open. So if this would have been sort of a proximal right coronary artery where you couldn't get, just the tiniest balloon through, or there's no way you can get a rota or shockwave in, then I would start with rota, and then probably after 1.5 rota, then go to shockwave balloon, if this is a 4.0 vessel, for example.
So I think we need to kind of remind the audience, which is mostly fellows, I think, that these are all high-end techniques. Okay, all what is talking about guide extension using a rotablation or a orbital atherectomy in an anomalous circle are all high-end techniques. And if you come across these cases in your first year out of practice or something, it's best to partner with a senior colleague, just so to learn from the experience and you have backup. And like how a microcatheter and a wire adds more power to the wire. When you work with a senior partner, it adds more power to you. So please, when you're coming across these cases, please partner up with a senior colleague to for the safety's sake and for your own well-being sake.
And I also wanted to emphasize Arasi's a great wisdom pearl there. If you can't find the right coronary artery, don't make assumptions. All right, you must follow through with a coronary CTA. You can't just assume and hope that everything is going to be amazing.
Okay, this is a great case, Krishnaraj. Thank you very much again, and we look forward to further submissions from you in future as well. This is a fantastic case that showed, it's almost a Dickensian type presentation. A tale of two CTs. Instead of that, you have a tale of 3 angiograms for us. So this is amazing. Thank you very much. Now we're going to move on to our next speaker, and we come back close home to Atlanta here with Dr. Valerie Efoi, who is going to be telling us about complex coronary atherectomy case with double jeopardy. And he is actually a board certified internal medicine physician who is a second-year cardiology fellow in Atlanta, Georgia at our Grady site. And he completed his medical training in Cameroon and has a master's in clinical research from Wake Forest in North Carolina. He's very interested in coronary interventions and is going to be doing to Milwaukee for his interventional cardiology fellowship. And we're very glad to have Valerie present here with us. Valerie, please.
Thank you, Dr. Kumar, for that great introduction. I'm going to share my screen. All right, can everyone see?
Yes, very good.
Perfect. So I apologize, I didn't use the C3 format for this slide template for this presentation, but I promise you it's going to be an interesting case. So we start off the day with a 63-year-old man who was diagnosed with invasive gallbladder carcinoma. About 1 year before we met him, he had undergone cholecystectomy. He also had diabetes, hypertension, hyperlipidemia, and this gentleman was referred to us from the oncology services for exertional substernal chest pain. He underwent an exercise treadmill stress test, which was abruptly ended at 5 minutes because he developed chest pain, which was limiting his exercise with a high risk Duke treadmill score. And so the patient was started on anti-anginal therapy and was also referred for coronary angiography. So these were the images from his first coronary angiography. As we can see here, there is a tight lesion around the proximal circumflex, about a 90% calcified lesion there in the proximal circ. And moving on to the LAD, so the LAD was diffusely diseased with about an 80% lesion in the proximal LAD. And he also had an intermediate grade stenosis around the distal portion of his right coronary artery. So he had triple vessel disease, he had diabetes, and so this patient was referred to CT surgery to consider for CABG. And whilst the CT surgeons were doing their pre-surgery workup, this patient was diagnosed with metastatic disease after he had a fine needle aspiration biopsy from some retroperitoneal lymph nodes. And he was subsequently started on chemotherapy. And given this new development, he was ruled not a good candidate for surgery. And so fast forward a few weeks afterwards, the patient was presented again to the hospital with some crushing chest pain at rest, which he said was relieved by sublingual nitroglycerin. And he was subsequently admitted to the hospital to evaluate for PCI. On the day of admission, his physical exam was pretty benign or remarkable. On labs, he had some moderate anemia. Hemoglobin had been stable over the last couple of months. Troponin was normal. and his EKG just showed some new T-wave inversions in leads 1 and AVL. And so using a heart team approach, and after a consultation with the oncologist, the patient was cleared to receive dual antiplatelet therapy. And so we decided to go and intervene on the proximal circumflex lesion, which we thought was the most critical lesion and was the culprit for this patient's chest pain, for this patient's recurrent chest pain. And at the start of the procedure, we couldn't get a fine cross microcatheter through that, past that stenosis. And so we went down with a rotor floppy wire. And we could get only up to this level with the rotor wire, and we met some resistance, so we couldn't advance past that level. And so we went on with the rotor ablation, did about 9 passes with the rotor. And at some point during the passes with the rotor ablator, as you can see on the left, the rotor burr, which was a 1.5 burr, came in contact with the distal ribbon of that floppy wire, which I think was where our problem started. And so after that, the rotor ablator was removed. Again, we went in, we tried to advance the fine cross microcatheter down that circ, but the catheter, instead of going to the circ, went straight into the LED, which was suggested that there may have been a problem, maybe fracture of that floppy wire, that distal floppy wire. So we went on and we did an angiogram, and not only did we discover that the wire had been fractured, the distal ribbon had been fractured, there was a perforation at the mid portion of the circumflex. And so immediately we decided to go after the perforation, which was the most significant complication and the one which could pose a lot of problems. So we had some difficulty advancing the balloon down to that level of the perforation. So we had to insert a guide liner, as you can see. We did a prolonged balloon inflation, about 3 minutes at this point. And at the same time, we were checking, doing an ultrasound, just to make sure that this patient had not developed pericardial effusion. At this point, there was no pericardial effusion. The patient was stable. And so we came down with the balloon, and then we decided to go after the wire. We decided to go retrieve the fractured wire, which was lodged somewhere in that obtuse marginal branch. We tried a goose snare neck technique. We tried a double wire technique, but both techniques were unsuccessful. And so the only other option that we had available to us were regarding the fractured wire. We decided to go ahead and stent that wire to the vessel wall. So we decided to go in with the first stent, which was a 2.5 18mm stent, and the stent couldn't get past this proximal part of the lesion because there was so much resistance. And so even using the guide liner, we couldn't get the stent past that lesion. And so we had to deploy the first stent there at the proximal part of the circ. And after that, so this is the angiogram post-deployment of the first stent. Again, we can see that there is still the perforation site is there, and then our fractured wire is still down in the OM branch. We decided to use a second long stent to go down to get to the wire, but we could not get past this bend where the first stent, at the distal portion of the first stent, we couldn't get past that bend with the second long wire. So we decided to go in with a shorter 2.5 8mm stent, as you can see. And again, at that point, we got some resistance moving down with that shorter stent. And so we had to deploy the stent at that part distal to the first stent. At this point, we post-ballooned and checked. There was no sign of pericardial effusion. And so we continued to move ahead to retrieving the wire. We tried a second attempt with a goose neck snare attempt to try to retrieve that wire down, which was lodged down in the OM branch. But again, this technique was unsuccessful. And so we continued with stenting with the aim of crushing that wire against the wall of the vessel before it could travel very, very far distally. Again, we went in with a shorter stent, which was the only stent which could, which was malleable enough to go across that bend. And even using the guide liner, we couldn't deliver the stent past that portion, which was just just distal to where we had parked the second stent. And at this point, we went in with the fourth stent, which was a much longer stent. This was a 225, 38 millimeter stent. So 225, 28 millimeter stent, sorry. And at this point, we had part of the wire. The stent was already covering part of the wire, but as much as we pushed the stent down to cover the entire wire against the vessel wall, so did the stent, advance distal. So did the fractured wire continue to advance distally, and so we decided to deploy the fourth stent at that point where it was, just so that we could, jail part of the wire. If we could jail just part of the wire, then we kept the wire from moving distally. And subsequently, we deployed two other short 8 millimeter stents to, completely jail the wire across the vessel wall. And again, throughout this procedure, throughout, this process of stenting, we're doing bedside ultrasound to make sure that this patient doesn't develop pericardial effusion and go into tamponade. And fortunately, at the end of the procedure, this is the final result we got. The fractured wire was jailed to the wall of the vessel, and we still had some evidence of perforation, though not as much as it was at the beginning of the procedure. And again, there was no evidence of pericardial effusion at the end of the procedure. The patient remained hemodynamically stable, and so he was sent over to the CCU. We got a repeat ultrasound that evening after the procedure. There was no evidence of effusion, and so we got ultrasounds daily just to make sure, the patient didn't develop effusion and tamponade. 24 hours after PCI, as you can see, there is some pericardial effusion which had developed, but again, there were no echo signs of tamponade. The patient was, hemodynamic-wise, the patient remained stable. And 3 days after the procedure, the size of the pericardial effusion had not increased. There were still no signs, no echo indications of tamponade. The patient remained stable, and so the patient was discharged. He was chest pain free. Saw the patient a month afterwards, got a repeat ultrasound, and there was a resolution of the pericardial tamponade without necessarily have to do pericardiocentesis. And so this was the case where we were faced with two different complications. We had a perforation of a vessel which was heavily calcified and tortuous, and we had difficulties advancing different be it stents or microcatheters, and also with the fractured guide wire. And so, my kind of lessons that I learned from this case as a second-year fellow is that you always have to stay vigilant whenever you're doing a case. It doesn't matter how simple the case is, because you may get into complications, and especially in complex cases as such, the risk of complications are really, really high. And when you're faced with a complication, you always have to assess, make sure that the patient is stable, patient safety first, patient is hemodynamically stable, and then you plan how to treat, plan how to manage your complication accordingly. And as I mentioned, we did encounter challenges during this case, primarily due to the fact that this was a heavily calcified vessel, and the vessel was also somewhat tortuous, which made it difficult to kind of maneuver long stents down to where the fractured wire was. Using repeated echocardiograms, we were able to make sure that the patient didn't develop pericardial effusion enough to cause tamponade. And we had to do our stenting from, in kind of a reverse order, rather than going distal to proximal. We had to go proximal to distal, just because we could not advance, the initial stents past the level of the stenosis or past those curves of the vessel. And another point I took away from this was, what works for one complication, what approach you use for one complication may not necessarily work when you are faced with a cluster of complications. In this case, we had a perforation, we did prolonged balloon in inflation, and we could have used reverse heparin just to minimize the risk of bleeding through that perforated vessel. But again, we're faced with a fractured guide wire, which poses a risk of thrombosis. So using a heparin reversal agent was out of the question for us. After failing with the glue snare technique or double wire techniques to retrieve the wire, we were left with the option of crushing the wire against the vessel wall. And, throughout the process, we made sure that this patient didn't develop, because the least amount of fluid that could have collected in the pericardial space in a short period of time may have tipped this patient over into tamponade, and then we'll be faced with a triple threat. And so I'd like to thank Dr. Sachdeva, who was an interventional cardiologist on the case and a great mentor to me. I'll take your questions.
That's a fantastic case, Valerie and Dr. Sachdev. Congratulations on a very difficult case that seems to have been managed very successfully. I think I just wanted to make one point about the short stents that are more deliverable. I think that's an important trick that we all need to remember. And the other thing, that doing those short stents with a fair amount of overlap, they also had a fair amount of overlap in that, close to that perforation segment. I think that's very helpful, because that can probably help to mitigate the effect of your perforation as well. Now, from your experience on CTOs, what are your thoughts about that, Arasi? And maybe Catherine can comment as well on your comment on doing that multiple overlap drug-eluting stent strategy versus a covered stent strategy, especially since you may not be able to deliver those covered stents to that position. Although I am told that the papyrus is a lot more deliverable, and that could potentially be a way out. Arasi, go ahead.
So, this is our game, right? In CTO, PCI, we leave behind gear all the time. It is annoying, but a true and real problem. So one of the first trick, which I want to talk about is when you can't deliver your rotofloppy wire further down beyond the area where you want to ablate, cutting the distal, the rotofloppy tip, the radiopaque tip, it's a 30 millimeters, and cutting it to 15 millimeters allows you to get your non-radiopaque part further down so you can ablate more. And so that's number one. Again, this is not for the first year fellow or post fellow person, but that's easily and safely done, very easily and safely done. So you're basically reducing the amount of the radiopaque portion, so you can rotoablate maybe 5 more millimeters. Number two, 2 layers of drug-eluting stents can be enough, especially in this case. At least from the angiogram, it seemed like an intramyocardial hematoma, like a ruptured and intramyocardial hematoma, than a free perforation. So in this situation, 2 stents would be 2 layers of drug-eluting stents should be enough. Okay. The third thing is sometimes getting the guide extension beyond your perforation site can buy you time. Even if you can't deliver a balloon, if you can get your guide extension catheter, that could buy you time. And sometimes if it is just the radiopaque portion of the rotofloppy, which is down the distal vessel, that can be left alone because it may not go anywhere. It's the floppy portion. It is not more thrombogenic. And I have at least 2 patients with rotofloppy, the radiopaque portion of the rotofloppy stuck in a septal or something like that. And that's their badge of honor right now. So these are my points.
Yeah, from the fellow's perspective, I'm the CHIP fellow at Henry Ford, and I also do a fair number of CTOs with my mentor here. And we also, as part of the game, leave a fair amount of gear in patients. And so I guess a couple points I would just point out is I wouldn't so much be worried about migration of the wire, which is what you had mentioned. It's not a hydrophilic wire. So when I'm thinking about, wires migrating and causing perforations at the end of vessels, I tend to worry much more about polymer jacketed wires than something like the roto wire. So the reason that I would want to pin it up to the wall is the risk of thrombosis, not really the risk of migration. And you were able to deliver stents and pin that wire up to the wall. So in this sort of kind of like an LS2 sort of perforation that looks like it's staining, this is a case that we would likely do at least partial reversal with protamine at the end of the case if we felt that we had pinned the entire wire up to the wall. So our practice, assuming we're therapeutic throughout the case with an ACT of 250 to 300, when at the end of the cases, we'll take a final picture, pull all the gear, and then we tend to give 25 of protamine. And so I probably would have personally given protamine in this case. But what you did of getting an echo on the table and serial echoes when you made the decision not to reverse is totally key to preventing something bad happening in the middle of the night. And I will say, you know, when you're taking care of, when I'm taking care of these patients post-procedure, I'm always taking them up to the ICU and always having a personal one-on-one conversation with the covering house staff, the covering nurse practitioner, the covering fellow, whoever's going to be responding to issues at the bedside, to know, hey, I'm worried that tamponade could be on the table. So if something is changing with the patient, think of it fast and call me.
So great case and good comments, Catherine. One thing that I just want to say is that you had difficulty delivering your fine cross catheter across this lesion. And one thing that I find very useful for delivering the wire, the rotor wire across, is to use something like Turnpike LP or a Corsair XS. And you know, hindsight is always 20/20. But you know, I really want to make sure that I deliver my rotor wire far out before I do that. And the same thing, you know, it's easy afterwards. But you know, I've had many cases that I've sort of regretted starting to stent proximal to distal instead of the other way around. You really have to think hard about before you do that. But Turnpike LP and Corsair XS are excellent for helping you bring your rotor wire really, or your regular wire out, and then following with Turnpike LP and then switching out for a rotor wire.
I had a question to the panelists. Would anyone have considered, at the point where they were able to deliver stents all the way down, you know, and kind of straighten out the vessel a bit, with the persistent perforation there, would anyone have considered trying to then deliver a papyrus into that spot to then cover the stent? I know it looked like it was stabilizing, the effusion wasn't growing, but would you have used that straightening of the line to see if that was possible?
Oh, Kwan, there was a lot of metal in there. So
yeah,
calcium, and you can see that I've stacked several stents.
Yep.
And there is a lot of overlap of metal, and then bringing another 2 layers of metal not only increases the risk of
papyrus is a single layer.
Yeah, so it becomes challenging. It becomes challenging especially when you have a guide liner and you're trying to shove things, and the guide liner doesn't go. One of the pictures you saw that the guide liner is pushed all the way out with just this 8mm stent, not just moving forward at all.
Right, but then
there was.
We get down like a very long stent for that last segment.
Mm-hmm.
Arasi and Catherine, just wondering about your opinion about that.
I agree with Dr. Sachdeva. It's going to be so hard, and I mean, sometimes pushing and shoving, you can tear it more. And patient is stable. You don't have you don't have an effusion. If there was ongoing perforation, or if there's ongoing tamponade issues and stuff like that, then pushing the envelope some more and delivering a papyrus or graft master, I mean, with a balloon, and get the guide extension down and deliver the stent, all that stuff would have been needed. But if the patient is stable, less is more. This is a metastatic cancer patient. This procedure was done for quality of life, and I think the procedure achieved that. I would walk away from it.
Yeah, I don't think in our lab we would do a covered stent, but from a technical standpoint, just I would probably see us delivering this with a guide extension and unsheathing it. And just, if you, for better or worse, I have a fair amount of experience with papyrus stents over the last number of months. And so I have knocked off papyrus. I've never used a graft master, fortunately. The papyrus, I'm told, hold on to the balloon a lot better, but I have knocked it off going into the guide liner from the back end. So I would give you the recommendation that if you are using a guide extension, which I think you would have had to do in this case, and you would have had to unsheath the PK papyrus, and I think you could probably have, since you straightened it out so nicely, you could have, balloon assisted tracking, inchworm, whatever you'd like to call it, the guide liner, and unsheath the PK papyrus. Please just bear in mind and watch when the PK papyrus is entering, not the guide liner in the vessel, but the distal part. because I have absolutely knocked it off. And then you deploy it and you're like, huh, that doesn't look very different. And then the way you get out of that is you pull it out with the balloon deployed to make sure you don't lose your PK papyrus in the body.
The stuff CTO PCI leads you to. It's unbelievable.
Okay, that was an excellent case again, and we're going to move on to our next speaker, Dr. David Tadden from Medical University of South Carolina, who's going to be telling us about the spider caught the thrombus. And Dr. Tadden is an interventional cardiology fellow at MUSC, and he completed medical school and residency in New Orleans, and worked for 2 years as an invasive cardiologist before deciding to return back to fellowship and do interventional cardiology training. He has a lot of interest in complex coronary artery disease and peripheral arterial disease. And please, Dr. Tadden, go ahead.
Okay. All right, can everyone hear me? Okay, so my name is David Tadden. I'm an interventional cardiology fellow at MUSC. And I would like to thank C3 Interventional Academy and my mentor, Dr. Maran, for allowing me to present this case today. So thank you. And the title of my talk is The Spider Caught the Thrombus. So the HPI for this person, he's a 61-year-old male, hypertension, hyperlipidemia, diabetes, recent COVID infection, 3 weeks prior to his presentation as a witness cardiac arrest. His wife heard a thud, found him unresponsive, and there was no bystander CPR. Upon arrival to the scene, EMS performed ACLS with return of spontaneous circulation. Total downtime was 10 minutes, and upon arrival to the ED, the cath lab was activated due to ST elevations. His vitals, he was stable initially, and physical exam, he was intubated and of course unresponsive. He had an airway in place. His labs prior coming to the cath lab, his pH was, these are kind of the labs we order quickly. pH was 7.05, lactate was 9.5. BU and creatinine 20, 2.4, hemoglobin 7.2, and his troponin was 1.59. Here's his EKG, kind of this group beating pattern. He had sinus tachycardia with Mobitz 1, acute inferior injury pattern with RV involvement, and low QRS voltage. Prior to pre-procedural management, he was given 300 of rectal aspirin, 4,000 of IV heparin. His airway was changed. He had arterial and venous lines. And he started to deteriorate due to bradycardia, hypotension, and acidosis. He was given IV bicarbonate and placed on an epinephrine infusion. Because of the hypotension, he had a right heart cath in conjunction with his left heart cath. And you can see his right heart cath numbers. He had elevated right and left-sided filling pressures. His outputs were not terrible, but he was on an epinephrine infusion. And his coronary angiography revealed an acute occlusion of his proximal RCA that you can see here on the cine loop. We obtained right femoral artery access, right femoral vein access. We didn't know if he was going to need some support during the case, so he received crushed Brilinta through his OG2. We used a 6-French GR4 guide. We used a hydrophilic FC wire to cross through the thrombus. And the cine loop that you see here is status post PTCA with a 2mm compliant balloon with restoration of flow into the distal vessel. And of course, you can see the heavy thrombus burden here along the proximal portion of the right coronary artery. We decided to repeat PTCA with a 2.5/40 compliant balloon. And we mostly IVUS, but unfortunately our equipment was not working. And so we could not use our IVUS. So we proceeded with stenting, a 2.5 long onyx stent, and post-dilated that with a 3mm non-compliant balloon. This is our final cine loop. It looked good, maybe a little bit of haziness right there distal to our little stent there. But we were okay with our result. And so after the case, he was transferred to the CVICU for targeted temperature management. We actually weaned off his epinephrine during the case, and he was stable, but about 8 hours after the procedure, he started having recurrence of ST elevations in his inferior leads. He had bradycardia and hypotension. He was placed back on vasopressors and a repeat EKG because of the recurrence of ST elevations. We brought him back to the cath lab emergently. And in the cath lab, I put a little echo, a bedside echo, just to make sure there was no mechanical or structural changes. He had a normal LV function. His right RV was somewhat dilated with mildly depressed systolic function. We went right radial access. We kind of knew his anatomy. We kind of figured what was going on. And we got left femoral venous access for a leave-in swan. We repeated the right heart cath. His filling pressures were basically the same left and right. His outputs were unchanged as well. He was on the label-fed drip. We went 6 French hockey stick, and we used a run-through wire. And as we suspected, he had an acute instant thrombosis. I didn't have a cine loop of that acute instant thrombosis, but what you see here on this cine loop on the left side of the screen was after PTCA with a 2.5 compliant balloon. And you can see there's a little bit of thrombotic irregularities in that stent. We decided to perform IVUS because our equipment was working at this time. This is kind of a sped up IVUS run through. And you can see there's diffuse coronary artery disease distal to our stent. And as we approach our stent, there is some mobile thrombus that you'll start to see here. And it kind of extends into our stent. And the stent's well opposed. So there's no distal edge dissection or intramural hematoma. So we decided to place, because of that diffuse CAD and thrombus, a 2.5 long resolute onyx stent, distal to our previous stent and overlapping our previous stent. We still kept seeing these thrombotic irregularities in our stent. And this is after ballooning with 3.540 non-compliant balloons, bigger balloons to try to break up that thrombus. So we decided to repeat our IVUS images, and our distal stent looked great, well opposed. There was no issues with it. But as we start getting into the proximal stent, there's still thrombus noted within the stent. You can kind of start seeing it here at 12 o'clock here and kind of coming down to 3 o'clock here. And then there's an area of a nice ring of thrombus that you'll see coming up shortly here. And then more proximally, the stent looked good. And so we tried aspiration thrombectomy with a priority 1 catheter with no success. We tried aspiration with a 6 French Godzilla with no success. However, we tried a 5mm spider filter. We placed it into our distal stent. We pulled all the way back from the distal stent, not coming out of the stent at all, into our proximal stent, into the retrieval catheter. And then pulled everything out. And I would have loved to put more pictures, but my presentation was limited on file size. But you can kind of see red colored thrombus fresh in our spider filter. We repeated IVUS again for the 3rd time. There was just a small amount of intraluminal thrombus. We ballooned that with a 4.5 non-compliant big balloon. And this is our final cine loop. A little sluggish flow in that distal PDA, and it looks, you know, a little occlusion distally. We were able to wean off the norepinephrine drip during the case. you know, he had gotten Brilinta the first time, and we were saying to ourselves, what's going on here? So we actually put him on an integralin drip for 24 hours. We were radial access, and we put him on a heparin drip for 48 hours. And he did well from a cardiac standpoint, but he really never recovered neurologically from his cardiac arrest, and supportive care was withdrawn and he was deceased. It's an interesting case. There's a lot of stuff in the literature about concurrent COVID, kind of this post-COVID, and it's starting to be realized that COVID-19 and thrombosis is associated with concomitant prothrombotic and pro-inflammatory states. Our patient presented with a thrombotic complication 3 weeks after COVID infection, and it also demonstrated successful thrombus removal with an open filter device refractory to conventional treatment. And that's my case.
Thank you very much. That was a great presentation. I notice Dr. Dave is here, and Raj, would you like to make a few comments as well?
So a couple of things, you know, it's an excellent presentation of stent thrombosis. You know, two things that I noticed was, one was that in the first time around, the patient was given crushed Brilinta, but was not given IV 2B3 inhibitors or Cangrelor. And secondly, when I look at the IVUS images distal to the first time placed stent, it appears that the vessel is a lot larger than the diameter of the stent which was placed the first time, even though this vessel looks terrible, and it's easy to misjudge the size of the stent. You know, but it seems like that distally the vessel was almost 3.5 millimeters on IVUS, and the stent size was 2.5. So there probably was a couple of, you know, things which may have occurred, you know, which may have led to the stent thrombosis event in this case. Now, you know, even though and this is more of a practice pattern issue, in our lab now, you know, in the last year and a half to 2 years, you know, we have really gone back to using POSIS angiojet. You know, for a while we had pretty much abandoned it, given that POSIS angiojet data in the old days was not very good with acute MI, and then at that time it was fallen out of favor because of aspiration catheters, and aspiration catheters fallen out of favor. But we find that angiojet works great, you know, for large thrombotic burdens, especially, you know, we have treated, you know, during the COVID pandemic, quite a few young patients who have come in with COVID-induced thrombosis. In fact, you know, about a month ago, I treated a guy, 38-year-old. They came in with a huge intralateral ST elevation and had massive, you know, size circumflex coronary artery with a huge clot in it. And we basically did an angiojet thrombectomy, and there was basically no lesion. It turned out to be, you know, COVID positive and was in the hospital several days with COVID infection. And we have seen these few cases now that, you know, the COVID patients are thrombogenic, and that may be something that to remember, that that there may have been a lot more clot, you know, than what meets the eye. So those are some of the things that, you know, I think learning points here in this case is importance of IV antiplatelet therapy, sizing of the stent, you know, obviously is important. You know, one question I do have for you, David, is why was IVUS chosen and not OCT?
Well, our lab, we mainly do the Boston Scientific IVUS.
Okay.
We don't have OCT.
Yeah.
We have
okay, well, that's fair. Yeah.
We have it at our VA lab, but not in our lab currently. So.
Yeah, no, that's fair. I think that, you know, we like, for this type of imaging, especially when thrombus is involved. We like OCT because OCT shows thrombus burden a lot more easier. It's easy to identify than IVUS, and also for stent under expansion. However, most of the time, I find, in this kind of cases, that I'm never successfully able to do OCT run in the beginning because there is just so much thrombus that you don't get enough clearance of the contrast to be able to get an OCT image. And I have to fix the problem before I can do the OCT, but it still is helpful. What do you think, Gautam?
So yeah, I think this is a very complicated case. There's plenty of risk factors for stent thrombosis in this case, starting with the patient substrate, starting with the recent, well, I guess with the COVID infection that's made things more complicated. I think, it's a well managed case in the sense that, there were a lot of curveballs that were thrown, nice off-label application of an open filter to achieve some kind of aspiration thrombectomy here. I think I'll have Dr. Sachdeva also comment on it, but he's had a fair amount of experience with penumbra catheter, CAT-RX catheter in some of these thrombosed vessels as well, which we have at some of our sites here, which has also been pretty good at removing some of this clot as well. In terms of stent sizing, when the patient's sick on an epi drip, these stents or these vessels always look small and clamped down. It looks like a 2.5 vessel. After a while, when that spasm and all that resolves, the vessel enlarges. So I wouldn't really make a whole lot of the undersized stent issue, because I think that's just part of the game that comes with these kind of patients who are on epi drip. And it's just something that we have to have some knowledge about and be prepared for. In terms of post-procedural use, post-procedural use of cangrelor may have been an option here. Some people would have run a 2B3A inhibitor from the word go, but then, remember the patient got CPR. If they have any rib fractures, then they could have a major hemothorax. Then you have a different problem to deal with. So, it's very complicated. Yeah, I would have thought about it, but, there may be other issues that come into the mix as well. Dr. Sachdeva, what are your thoughts about the penumbra?
So you can use penumbra, but I think when you have such a high clot burden, penumbra may not be sufficient to actually suck out the clot, and that you may need to use angiojet. And even with the angiojet, you may not be able to get the clot because the clot is layered. If you are really sort of bothered with the clot, you had a flow there. The other thing which I learned from you is to actually give a little bit of TPA. A 2 milligram of TPA through a perforated balloon may break up this clot, and it can actually get dislodged from there and go into the distal vasculature. So that's another strategy. If the clot which is there is bothering a lot, and you want a sort of a perfect angiographic result, then that you can use that. But I think when you do these imaging modalities, especially OCT, you're going to see a lot more, plaque protrusion and a clot. It doesn't make you feel good.
There's one good question in the audience about use of excimer laser for thrombus. I think obviously it's a great idea to use a laser device, not universally available everywhere, however. And then there was another question about use of 2B3A and unfractionated heparin together. That's pretty standard for this type of procedures. We in our lab nowadays use much more cangrelor than 2B3A inhibitor, and because of several advantages of cangrelor over 2B3A inhibitor, especially the short half-life of the drug, so it can be discontinued.
So we did think about laser. I think if we hadn't retrieved the thrombus and if the flow hadn't improved, we would have thought about laser. Angiojet, this patient was already bradycardic when he brought, so we would have had to increase, place a temp pacer, etc. I think another point from the beginning of the case is I have a little bit of a, what do I say, a thought block with these post-cardiac arrest patients who are found down, because even though the family says it was 2 minutes, he just passed out for 2 minutes, it's truly never 2 minutes, it's probably 10 minutes. And that's literally what happened with this patient. He had complete anoxic brain injury. So overall, in general, these post-cardiac arrest patients who are brought straight to the lab without demonstrated neurological recovery, I always find it a suspect and kind of, I think of, okay, less is more, let's get him back for all the post arrest recovery process. And definitely, in South Carolina, at least in MERC, we've been very lucky with the COVID issue. We've not had a whole bunch of post-COVID patients. So I think our experience with this post-COVID thrombotic cases was much limited. Otherwise, we would have been extremely aggressive with Cangrelor or even 2B3A from the get-go. Our usual STEMI patients, we preload them with DAPT at the ER, and we've not had any issues with stent thrombosis. But laser is a good, and we did think about laser, and all the other points were very well taken and all well appropriate to the case.
Yeah, Arasi, I thought that was a great use of the spider filter. I would say though that I've had a case before where the spider filter, especially if it enters a stented segment, I've had a case before where the spider filter got trapped within the stent and could not be entangled, after which we had to aggressively pull the whole thing out. So I think anyone else were to consider using this technique again, it's definitely better off in a non-stented segment than in a stented segment, because you can sometimes really get into a lot of trouble there.
Yeah, we were very careful to keep it within the stented segment, because the vessel is a small, fastened, kind of not so looking vessel. We chose a 2.5 stent just because the distal vessel wasn't big, and we thought we can use a 3.0 balloon and expand it much more. We were going for the approach here just to get the patient, just do the less is more strategy.
Well, Kwan,
I'm glad I didn't
invite you to talk about your spider filter adventure, because I know you had told me about that in the past. That is a great case, Dr. Maran and Dr. Tadin. Thank you so much for presenting this. I'm sure you will have more complications to show us in future, and more complex cases to show us as well in future. So I think we will move on to the next speaker, Dr. Catherine Kunkel. She's a CHIP fellow, and she was kind enough to graciously comment on a few things earlier as well at Henry Ford in Detroit, Michigan. She has done multiple fellowships in general, interventional, as well as structural fellowships at Penn, as well as her master's degree in medical education. Her main interests are in mechanical circulatory support, medical education, as well as complex PCI and CTOs. Dr. Kunkel, please.
Hi, everyone. I will try to go quickly and be respectful of everyone's time this morning. Thank you so much for the organizers for the opportunity to share a case with you, with the group this morning. So I'm going to share a case of the use of the open sesame technique to facilitate wiring a difficult lesion. So our case is a 63-year-old gentleman. He has multiple risk factors and coronary disease with a prior cabbage. And he presented with CCS class 3 angina to our outpatient practice despite 2 anti-anginal agents. So in terms of his coronary history, his cabbage was back in 2004. He had a 4-vessel cabbage. And over the years, with recurrent episodes of angina, he's had repeat angiograms, and over the years has occluded the 2 grafts going to the obtuse marginal system. So currently, we know that most recently, as of 2019, he had a patent lima to LAD and patent vein graft to the right. You see his medication list, which includes a long-acting nitrate as well as a beta blocker. And here's his vitals in clinic. So before the patient had seen us, his general cardiologist had done a fairly thorough workup. The patient had had a Percutaneous SPECT, which showed a large reversible defect involving the entire circumflex territory with a preserved ejection fraction and no regional abnormality, wall motion abnormalities noted on that. His most recent EF assessment was in 2019, which was normal on left ventriculography. And his EKG in clinic was normal sinus rhythm. There were no Q waves noted. So when he came to see us, he had had a recent diagnostic angiogram. And I've selected the two best images you can see of the left system. So here you can see he has a very high-grade, heavily calcified distal left main lesion going into either a ramus or a first obtuse marginal. And then he has a quite large obtuse marginal system that's covering the entire lateral wall of the heart that you would probably grade kind of TIMI 3- flow and competitive flow in the LAD. Here you see his lima to the LAD, which is widely patent and free of disease. Further diagnostic angiogram, his native right is occluded, but the vein graft to the distal RCA, which is giving rise to the RPL system, is widely patent. The operator did an angiogram to make sure there was nothing being missed in the root, and you see, fortunately, this patient did have graft markers placed, and there are no additional patent grafts noted. So when we discussed with the patient, and he opted to proceed with complex PCI for revascularization of this large obtuse marginal territory that has been seen to be causing ischemia of the lateral wall of the heart. So these were our anticipated challenges walking into the case. There was some ongoing ambiguity of what exactly is happening at a left main trifurcation. Unfortunately, there were really no good caudal views or very caudal views taken on his initial angiogram. So that was something we were going to have to sort out. Also significant calcification. We thought there was likely a retroflex takeoff of the left circumflex and a long diffuse disease segment, which we were likely going to have to treat all of. So this case, we knew from the beginning was going to be won or lost in wiring this circumflex, which turned out to be considerably harder than anticipated. So we started by taking this angiogram, which was probably about 40 degrees of caudal. And here you can see we've clarified the anatomy. It's actually the branch that we had thought was a ramus is a high-rising first obtuse marginal. And then the branch that we'd like to stent into is a second obtuse marginal. You see the origin of the circumflex here is essentially a pinpoint retroflex takeoff from this vessel. So to further clarify anatomic ambiguity, we decided to proceed with IVUS next to help us understand exactly where the takeoff of that origin was. Here you see the IVUS findings. So this is from that first obtuse marginal pulling back. And if you see down at 5 o'clock, this is actually, sorry, I pulled back real slow. That was the AV groove circ coming in. And now you'll see we're coming back into the left main. We have 180 degrees of calcification. So at this point in time, we attempted to wire, we performed CSI into the first obtuse marginal after we unsuccessfully attempted to wire the continuation of the AV groove circ. And the thought on this was to modify the proximal portion and to debulk the plaque to allow us access to the circ. And so we performed CSI into the first obtuse marginal. We exchanged our Viper for a workhorse. And then we spent the next, long time attempting to wire this branch. And we used a lot of the techniques that we use in complex PCI. We used multiple microcatheters, a dual lumen microcatheter. We used the Sasuke catheter most frequently in our lab. We also used angled microcatheters, including a Supercross 120. And then we selected a variety of different wires with different characteristics. My workhorse is generally a run through. We upgraded and tried with a polymer jacketed wire, so a Fielder FC. And then we did make an attempt with a Gaia Next 1 wire, which is one of the Asahi kind of CTO specialty wires that is particularly marketed for its one-to-one torqueability based on the engineering of the wire. And despite all of this, we were unable to wire the circumflex. Oh, sorry. So then we made the decision to proceed with an open sesame technique. So in CTO PCI, the open sesame technique is used for a difficult to enter proximal cap when the proximal cap is located at a side branch. And so essentially you do PTCA across the origin of the lesion of interest in CTO, the proximal cap. But in this case, the origin of the circ to alter the geometry and to alter, to essentially crack the plaque in the proximal cap to allow, to facilitate wiring. Fortunately, that was successful in this case. It was easily, after we performed this maneuver, it was easily wired with a workhorse wire. We pre-dilated the lesion and then proceeded with stenting. We stented the left main into the circ. Based on this angiogram, we went back, re-IVISed, and decided to treat a little bit more distally to land in a disease-free zone. And so we ended up stenting into the second obtuse marginal, and this is our final result. So there were a lot of takeaway points in this case for me. First, I think good angiography and intravascular imaging are critical in clarifying anatomic ambiguity. And if I'm struggling and having a lot of difficulty executing a step of a PCI, this is a step I go to pretty quickly to try to understand anatomic ambiguity. This case also illustrated some of the steps on the algorithm in working through difficult to wire situations, including choosing wires with different properties, using both straight and angled microcatheters, dual lumen microcatheters, as well as cap modification, which we often do with rota or orbital atherectomy essentially interchangeably. And finally, this is a case illustrating the use of a CTO technique, which can be applied to non-CTO PCI to solve some technical challenges. Thank you very much.
So that was a very nice case. I have a couple of comments. I think the majority of the difficulty wiring a circumflex in this sort of scenario is because you don't have enough space in the left main to sort of twist or probe the circumflex, because one, the plaque has sort of taken majority of the space and it has given such an acute angle that when you even engage it, you can't push it, and if the push goes forward instead of actually getting transmitted towards the tip of the wire. So this could be a scenario, especially in a LED diag disease, and you're trying to actually wire the diag, and think about the plaque actually protrudes, going downwards, and then you have to sort of come back with the wire to actually engage the diag. And, in this sort of scenario, ballooning that area to create a little more space, so then you have a little more wiggle room with the in the space, and then you can actually use the wire to actually try to go through there. And I have used a Fielder XT, which is a tapered tip, as well as a hydrophilic wire, which gives you sort of not only just it's a flimsy wire, but also engages it, and you have to just sort of then twist it to navigate that area, and then I think it actually passes through. Then you can use other hydrophilic wire. If you use a hydrophilic wire which has more body to it, like a Pilot 200 or 150, I think it becomes more challenging because you don't need that much push. You need just entry and just wire to find that space and go down there.
Yeah. For the LED diag situation, we often solve that with reverse wiring technique with a dual lumen microcatheter. But we in this case, unfortunately, we thought that OM1 kind of the running room to do a reverse wiring technique wasn't long enough to be able to unfold the wire in the distal vessel. And yes, the idea of kind of spinning into the side branch, I will always have my mentor's voice in my background, because it's exactly as you say. As a fellow, I certainly have the tendency to want to push and it's only going to prolapse the wire. So I just hear my mentor's voice going, finesse, finesse. But yeah, that's, I think, a challenge and one of those feel of the wires experience things that I think we all, as a fellow myself, I hope I gain over time. I
think this is a very difficult case with difficult wiring strategies. I think a Sasuke might have worked here with dual lumen microcatheter that might have actually gotten access.
We tried that, unfortunately.
But as I said, we don't have a whole lot of run up there distally, and that could be a problem.
Yeah.
The other option that you have is also suggested by one of my panelists as well, which you can basically put a little balloon there distally, inflate that balloon, and actually force the wire into the side branch that way. And you might have tried that technique as well. But as I said, there's not a whole lot of running room proximally, and that's really the biggest problem in this case. We'll take comments from the rest of the panel. One quick comment from Kwan, Dr. Maran, and Dr. Olive Krona, and then I will have Dr. Dave close the session.
So my balloon occlusion technique, as discussed, is a very useful one. The only point I would like to make about that is you want to make sure you have a very low penetrative power wire, either like a Ceon blue, or even a Suo wire where it just prolapses into the vessel. You don't want to use a high penetrative tip wire for the balloon occlusion technique.
Yeah, and Dr. Maran, can I ask you one other, just a follow-up question? Because the thing that always goes through my head with this technique is what happens if you close the vessel down? What's your bailout here? And so, the only kind of bailout that was in my head is if we had shut down the os of this vessel with this maneuver, would have probably been to knuckle and hopefully re-enter, but star if as an absolute bailout. Yeah.
Yeah, I just thought that was a fantastic.
Star would be
yeah.
The thing is, the calcification protects you a little bit. If it's an acute thrombotic situation, then prolapsing would be difficult, and you can actually shut down. But this is a stable coronary artery disease with a lot of calcification. The calcium actually could protect you. And if that happens, and if you still shut down, use a bigger balloon in the left main, create a dissection, and star it down and rescue the vessel would be the bailout.
I think it was a great case. Thank you for sharing. And those difficult right takeoffs after stenosis and the circumflex are really difficult. I don't know, it was mentioned earlier, but going down with a dual lumen catheter with a folded wire and creating a hairpin maneuver it would have been something that I would have sort of tried to do if possible. You also have the possibility of perhaps also checking out the vein grafts, because vein grafts, even though they're old, are sometimes quite easy to go through and go up that way and securing it. That's one other possibility. And of course, also using a balloon inflation with microcatheter and knuckling down, like was mentioned, is also sort of a bailout base technique, essentially from the left main down to the circuit. A great case.
Thank you.
Raj, closing comments?
Fantastic session, amazing cases. I'm very impressed by the complexity of the cases that were presented today. All great learning points, tremendous panel. This is, something I'm very proud of, that we continue to support our fellows, and I want to do more for them. And thanks all the panelists, including yourself and Dr. Maran, Goran. I see lots of other international panelists who are, speaking through chat. Dr. Kwan Lee, I think is on the West Coast now, taking a, early morning for the fellows course. So thank you very much, everybody, and have a great rest of the weekend.
Thank you, and have a nice weekend.